So just like we did at the hip, we talked about the osteology. Now we're going to talk about the stability and the motion of the knee. So of course, stability and motion are on a spectrum with stability at one end and motion on the other. The more motion you have, the less stable it is. The more stability you have, the less motion you have. So we're going to talk about the structures that stabilize the knee, and we're going to talk about the normal motion at the knee. So the first set of ligaments that we're going to talk about, of course, our ligaments are often our supporting structures as well as muscles, but we're going to talk about the cruciate ligaments, anterior and posterior cruciate ligaments. So of course, you hear about these all the time, people getting injured doing sports, tearing their ACL or PCL, or both, just for fun. Cruciate describes the X shape of the anterior and posterior cruciate ligaments as they interconnect with the femur. So the cruciate ligaments are the most important stabilizers of the knee in the sagittal plane. The anterior cruciate ligament is probably the most frequently injured during sporting events that generate a combination of rotational, valgus, and hyperextension producing knee forces. So anything where you plant your foot and somebody tackles you from the side, that puts your ACL at risk. So these pictures are in the book, and I love these pictures, I'll just gotta tell you, and they're much bigger in the book than what you can see here. But just while these pictures are up, I'm going to talk about what the ACL and PCL do. So we have to talk about open chain and closed chain because we use our knee in both. So in open chain, the ACL, it resists anterior translation of the tibia relative to a fixed femur. That's the open chain. In closed chain, it resists posterior translation of the femur relative to a fixed tibia. Okay, so if you think of the tibia as one of the tests that they do to test the ACL is called the anterior drawer test. If you think of being the tibia being the drawer, like you're going to pull the drawer out, the ACL resists that motion. So if the femur is fixed and the tibia is not, you're pulling the drawer forward. If the tibia is fixed and the femur is not, you're pushing the femur backward, posteriorly. I hope that makes sense. The posterior cruciate ligament is just the opposite. So in open chain, it resists posterior translation of the tibia relative to a fixed femur, so you're pushing the drawer in. And in closed chain, it resists anterior translation of the femur over relatively fixed tibia. So closed chain versus open chain, it's the same motion, it's just how we're looking at it in terms of perspective. So take a look at these pictures in the book, and I'll tell you what they're on page 278 and 279, just to get the idea. And you can see how, and it's a lateral view, you can see how the ACL goes from posteriorly on the femur to anteriorly on the tibia, and the PCL goes from anteriorly on the tibia to anterior on the femur to posterior on the tibia. So you can see how it resists those motions. Okay, so take a look at those pictures, try to visualize how it's resisting the motions. Look at a lot of pictures, look at bony models. Check out your own knee, see what you can see there, to get an idea of how this works in 3D. When you're looking at flat pictures, it can be really hard sometimes to visualize that 3D. Check out some of the videos that I've posted in the module. They have animations of those so you can see the motion a little bit better. Sometimes that helps. But and also if you think about that anterior drawer test for the ACL, that kind of helps me, like, oh, I'm pulling the tibia out, I'm pulling the drawer out. I'm pushing it in, I'm pushing the drawer in. So hopefully that'll help you get your mind around what the ACL and the PCL do. So The medial and lateral collateral ligaments, they strengthen the medial and lateral sides of the knee capsule to prevent or to protect against excessive genu varus or genu valgus. Genu varus is the knee going laterally. Valgus is the knee going medially. So the medial collateral ligament spans the medial side of the knee and resists valgus-producing forces. So forces that are pushing from the lateral side of the knee medially. That's a valgus force. The medial collateral ligament becomes taut at full extension, so it's useful for locking the extended knee while you're standing. That's a very stable position. So when you look at this, this is a cadaver anatomy picture. You can see how beefy those structures are. So the tendons you can see are sort of whiter. The ligaments are sort of pinker in this picture. But you can see how big and strong those structures are to stabilize the knee, which is cool. So this is our ACL, PCL, or sorry, MCL, LCL view. So on the first one, the unstressed knee, you can see the ACL and the PCL in there, and then the lateral and medial collateral ligaments on either side. The valgus producing force, which is coming laterally, moving medially, that is more common because it's pretty hard to hit someone on the inside of their leg, if you can think about it that way. That stresses the ACL and it stresses the medial collateral ligament. The varus producing force, which is going medially to laterally, less common. It stresses the PCL and the lateral collateral ligament. So you can imagine when you're playing soccer, or you're playing football, or any contact sport, valgus producing forces are much more common. The other thing, when you're doing things like skiing, as you put pressure on the ski to weight that inside edge, you are producing a valgus force. And so valgus forces are much more common, therefore MCL and ACL injuries are more common than LCL and PCL injuries, just because of the way the forces go. And the other leg is producing you from a lot of protecting you from a lot of varus producing forces. The valgus producing forces are coming from the outside, so it's just more common to have those type of injuries. The medial and lateral meniscus are crescent-shaped fibrocartilaginous discs that are at the top of the tibial medial lateral condyles. So like the acetabular labrum deepens the socket, the menisci also deepen the socket a little bit, even though certainly not as much as the acetabulum, but it stabilizes the joint. It also it's pretty thick, and it absorbs compressive forces across the knee caused by all those big strong muscles contracting and then just the weight of your body on your knees. And it reduces pressure across the knee. So, of course, these pictures are from the book, and it shows the ligament attachments and their relationship to the cartilage of the meniscus, which is pretty cool, actually. But the second picture, it shows the vascularity of the meniscus, and you can see that interior part of it does not have a very good blood supply. So a lot of times meniscus tears, how they heal depends on where they are located. And whether or not you'll need surgery depends on where the tear is located. So if you have a tear in the outer area, it might heal better because it has better vascularity. In the inner area, it probably won't heal, and you'll have to get part of it removed. So when, 20-something years ago, I had a classic valgus producing stress while I was skiing, tearing my medial meniscus, and I had to have surgery to get part of it removed, and so now I just have a partial meniscus in my right knee, which makes it all the more important to keep my muscles strong to stabilize that joint. The posterior capsule prevents hyperextension of the knee. It includes two major ligaments, the arcuate popliteal ligament and the oblique popliteal ligament. A knee that is in marked hyperextension also known as genu recurvatum, has the strain on most of the knee structures, including the posterior capsule. So the next time you're walking around town or waiting for a bus or at the mall or in the grocery store, check out people's knees when they're standing. Look at their, are they hyperextended? Are they neutral? It's especially easy to do that in the summer because people are wearing shorts. You can see what's going on with their knees. It's maybe not as easy to do when in the winter when people are wearing long pants, unless they're tighter pants. But the posterior capsule is quite extensive, covers a lot of area, and it prevents a lot of stresses. The other structures, like the medial collateral ligament and the lateral collateral ligament and the ACL and the PCL, are in their stretched position when your knee is extended, and so they're stabilizing that standing position. So there's a lot of ligamentous and muscle support that goes into stabilizing our standing position. So the tibiofemoral joint allows 2 degrees of freedom. Flexion and extension occur in the sagittal plane about a medial lateral axis of rotation. And internal and external rotation of the knee occurs within the horizontal plane about a vertical or longitudinal axis of rotation. So that internal and external rotation of the knee is not necessarily a voluntary movement, and it's not a big movement. We're not like, oh, I'm going to internally and externally rotate my knee, just like you do your shoulder. But functionally, it occurs as we extend our knee into full extension. And we'll talk about that. It's called the screw-home mechanism. So in open chain, the arthrokinematics are based on a concave tibial condyle rotating around the convex condyles of the femur. And so when the in open chain, we have roll and slide in the same direction. In closed chain, it's roll and slide in the opposite direction because it's the convex femur on the concave tibia. So the arthrokinematics for knee flexion are just the reverse for knee extension. So it's those same 2 rules. When concave is moving on convex, we have roll and slide in the same direction. When convex is moving on concave, we have roll and slide in opposite directions. So I hope you got to try that with some bony models in the lab and that it makes a little bit more sense to you. When you're looking at regaining motion after surgery or after an injury, that's when this stuff really starts to make sense. Flexion and extension of the knee are accompanied by the slight rotational movements. So as the knee nears full extension, the knee rotates externally about 10 to 15 degrees. And this automatic rotation assists in locking the knee. It's called the screw-home mechanism. So I have 2 or 3 videos posted in the module to help you visualize that screw-home mechanism. One of them is an animation. One of them shows it on a person, which is a pretty good way to do it. And you can actually do this on yourself, which is kind of neat. So if you get a chance, watch that video. It's pretty short. I think it's about 2 minutes long. And then you can try it on yourself and you can visualize that screw-home mechanism. So the osteological reason for the screw-home mechanism, or the reason we can do it, is because the medial femoral condyle is actually a little bit longer, about a ½ inch longer than the lateral femoral condyle. So as knee extension occurs, the articular surface of the lateral condyle is all used up, for its rolling and sliding, while there's still about a ½ inch medially. So the medial condyle has to glide posteriorly to use all of its articular surface. And with knee extension and non-weight bearing, you get external rotation of the tibia. So when in weight bearing and closed chain, you get internal rotation of the femur on the tibia. So the patellofemoral joint, it's the other joint of the knee. It's the articulation formed between the posterior surface of the patella and the intercondylar groove of the femur. So the patella, it enhances the torque-producing capability of the quadriceps by about 25% by increasing the moment arm. So after a patellectomy, where you have your patella removed, the quadriceps are at a disadvantage. They have to produce 25% more force in order to get the same motion. So the increased muscle force can cause fatigue and also damage to the joints. So I've actually worked with one lady who had a patellectomy many years ago, so she's been walking around for years without a patella, and she really didn't have very good knee extension because of that, because her quadriceps lacked the force in order to do that. And she eventually ended up getting a total knee replacement, and that's when I worked with her, when she had her total knee. So the upshot of not having a patella for years and years is her quadriceps were super weak. So we had to work a lot harder with her to get quadriceps strength back after her total knee replacement than we did with someone who had normal quadriceps strength before their total knee replacement. So the Q angle, or patellofemoral angle, Q stands for quadriceps, and Q angle. It's the angle between the quadriceps muscle, or mainly the rectus femoris, and the patellar tendon. So because of the way the shaft of the femur moves from lateral to medial, there's that little angle. There's actually that little angle between the quadriceps muscle and the patellar tendon. And the normal angle, you'll see different things in different books. I've seen some books where it says 10 to 15. Our book says 13 to 15. So we'll just say around 15 or maybe a little less. Q angle tends to be slightly larger in females. That doesn't mean that all females have a large Q angle. It means, on average, Q angle is slightly larger in females. So the functional significance of the Q angle is if you have an excessive Q angle, it can affect your patellofemoral tracking. So one of the groups this week has assigned to them large Q angle as affecting patellofemoral dysfunction. And so we'll see in the next lab what that group came up with for research and how that is affected. So in this picture from the book, it shows the different force directions, the laterally directed forces versus the medial directed forces. And you can see if there's a larger Q angle, you're going to have more laterally directed forces, so or stronger laterally directed forces. So the potential for lateral patellar tracking is greater when you have a bigger Q angle.